Hello, I am Anil Gudi and my colleague Amit Shah. Both of us run this course in reproductive medicine and IVF. And I'm going to ask a few questions to Amit about generally about the analog trigger. We have had a very robust discussion. It's taken hours of discussion of how IVF is changing. And I want to ask you a very controversial question, Amit. Is it time for normal responders, poor responders, and for PCOS, is it time to say no to HCG?
Absolutely. I completely agree. I am convinced that using HCG in these days and age and modern times is not the right thing. The main reason for that is, as you all know, and we all know, and we had again had a good discussion, that HCG is the main culprit behind the ovarian hyperstimulation. And ovarian hyperstimulation is a complication of IVF, which is iatrogenic and which is totally unnecessary.
The largest queries that we got here was people were concerned that an analog trigger would give you less eggs. What is your experience about it?
Contrary to what people thought, I think it doesn't matter which trigger you use, whether you use HCG or whether you use the analog trigger, which in other words some people call it an agonist trigger. The failure rates, the number of eggs that you get, and more or less the quality of eggs you get are equal. So there is no difference whatsoever. It's a misconception over the time that people have developed that analog trigger doesn't work.
The other controversy which we often come across is what is the dose of an analog trigger? We see many people saying it is Biserelin, which we use, it's 0.5 milligrams, somebody says 1 milligram, somebody says 2 milligram. What would you think, what does research tell us about this?
Well, sadly, there is no consensus about the dosages because there has been no dose-finding research on these sort of strategies. And if you look at the published data, then you will see that people have used from 0.2 milligram going up to 3 and 4 milligrams for trigger. And of course, the worry has been that if we don't get enough, we may not get enough eggs, or we may get more immature eggs, or the likelihood of failure increases, which is not true. And in my experience, we have obtained eggs which are mature eggs with even a dosage of 0.3 milligram of buserelin. So it doesn't really matter.
Is there any way that you can check? As you know that our institute is doing one of the largest studies on the efficacy of the analog trigger. In your opinion, in your practice, what would you do post-analog trigger to check if there has been the surge of LH, and what do you normally do?
Yeah, I believe that it's better to be safe than sorry. We all know that there is an inherent failure rate of all trigger strategies, whether it's an HCG or whether it's an agonist analog trigger. And thankfully, because we use mainly analog triggers now, it's very easy to measure whether it has worked or not by a simple blood test measuring LH levels, which is a serum LH, or you can even do, if you don't have the facilities for a quick turnaround, you can even do a urinary LH level. And my strategy would be that from the time that you have given the analog trigger, generally within 10 to 12 hours, you must look for LH either in the urine or in the blood. And if it shows that you have got a positive LH surge on a urine sample, or if you have got a level of 15 international unit per liter of LH in your blood levels, then you are almost certain that the trigger has actually done its job, and you can very calmly and confidently move ahead with your egg collection 35 to 37 hours after the trigger, just like the HCG trigger, which actually is a benefit over the HCG, because when you give HCG as a trigger, you will not be able to check before the egg collection, that is before the day of egg collection, you may be able to get a positive urine pregnancy test or a blood HCG in the morning, but then it's a bit too late.
I agree that in the cases of PCOS, I think it would be not justified using an analog trigger. I think we had this discussion today that I would also agree that in case of poor responders and in cases where you see a large number of immature eggs, that we should give it a trial with an agonist trigger, and that may change the outcome, though I don't think we can be very certain about it.
Well, my view is that it doesn't matter whether it's PCO, whether it's a normal responder, or whether it's a poor responder. We need to start to move towards agonist or analog trigger. HCG is a thing of the past, especially when we are looking at the way science is moving forward and people are moving more and more towards elective freezing of embryos and frozen embryo replacement cycles. Also in cases of egg freezing, etc. I don't think that we should be exposing this young, healthy bunch of patients to HCG and the potential risk of ovarian hyperstimulation. And you know that it doesn't matter whether there are 6 follicles or there are 27 follicles. Once you give HCG, you are likely to get ovarian hyperstimulation without doubt. Either it's mild, moderate, severe, it doesn't matter, but people will get it. While with analog trigger, I am aware that you cannot prevent it 100%, but majority of moderate to severe ovarian hyperstimulation will be prevented. Patients will stop going into hospitals and intensive care, and we will make IVF safer, because this is the biggest risk factor with the IVF treatment cycle, because it can kill people.
Thank you very much, Amit.
Thank you.
I think it's been a very good 4 days. Yes. I think we look forward to 2 more days of good discussion.
Indeed.
Thank you.
Thank you very much.